Welcome to Action on Pain, a podcast dedicated to highlighting the significant efforts underway in Canada to address chronic pain.
By presenting perspectives from individuals who live with pain, researchers, clinicians, and other stakeholders, we explore various impacts on people's lives and the initiatives, research endeavors, and the committed professionals working to effect meaningful change.
This work is guided by Health Canada's Action Plan for Pain. Join us as we raise awareness and share stories that are shaping the future of pain management in Canada.
Welcome to Action on Pain. I'm Keith Meldrum, and as always, I'm joined by Jennifer Daly-Cyr and Virginia McIntyre.
Oh, that's great. Thanks, Keith. And I'm Jennifer Daly-Cyr, and it's so important to keep these conversations going and shine a light on the amazing initiatives that are truly making a difference in Canada.
I'm Virginia McIntyre, and I'm here with Keith and Jennifer.
And in each episode, we're aiming to unpack different facets of the action plan, understand the education and research that is driving it, and connect with so many incredible individuals dedicated to improving the lives of Canadians living with pain, like our wonderful guest today.
And it is my absolute pleasure to welcome today Dr. Gabrielle Pagé for joining us. Dr. Pagé is an assistant professor at the Department of Anesthesiology and Pain Medicine, the Faculty of Medicine at the University of Montreal. She's an award-winning scientist and the winner of the Canadian Pain Society's Early Career Award winner for 2025. Congratulations. We are so eager to hear about your research and your insights for all those impacted by persistent pain. Dr. Pagé, it is a pleasure to have you and welcome in joining us today.
Thank you so much for the invitation. I'm really thrilled to speak with you today.
Gabby, I first want to congratulations on your award. And it was a pleasure actually to be in Toronto and see it presented to you. So we're going to ask you a couple of questions. So, you and your lab do some fundamental pain research, both in basic and clinical science. I'd like to know, and I've done some work with you, a little bit more how you engage patient partners and how this is advancing the action plan on pain. Like I know we've done some work, myself as a patient partner with Canadian Pain Society, and we've done some on research. So I'd like to expand on that a little bit more.
Yes. So there's different ways that we do this, and each of those ways confirm the importance of having people with lived experience helping us make research that is meaningful and that is actually addressing questions that are important to advance the field forward. Let it be more fundamental research or let it be more clinical or applied research. So I have examples of some projects where the idea itself is initiated by people with lived experience who come and speak with us and say, hey, I'm interested in this topic. I think it's really important to move this forward. And I have other research where the idea comes more from, let's say, my clinical experience, where as a psychologist, I see people living with pain who often have a long trajectory of navigating the healthcare system. And I'm in a tertiary care, like specialized clinic. So by the time they get to me, oftentimes that trajectory has been really suboptimal in so many ways. And you can see sometimes the consequences of this in terms of how they live with the pain, how they think about the pain, how it's impacting different spheres of their life. And sometimes as a clinician, I feel a little stuck. I'm saying, well, we don't have good science that I can really rely on right now to help the people. And sometimes that stirs up some research projects where we're trying to further understand as a psychologist, I'm understanding the cognition, so the thoughts or the behaviors or the reactions to what they've been told about their pain. And sometimes that stirs up research projects in bringing on some of that knowledge into the clinical practice.
That sounds amazing. I know, as Virginia mentioned, I've also had some opportunity to work with you on some projects, which have been fascinating. So, yeah, we would love to hear about some of your examples of these two sort of lenses of research. So, please share.
Where to start?
Wherever you think is best. So,
and you guys have been amazing working on research projects, and your impact has been so meaningful. So thank you.
Well, thank you
to all of you.
Yeah.
I think maybe I'll try to give like 2 examples. So one where sort of the clinic has informed the work we're doing is the project we have on stress and pain. And this really started with a conversation in a hallway with one of the physicians at the pain clinic who stopped me and said, "Hey, Gabby, I have a patient that I don't really know what to do anymore. There seems to be a lot of fear of pain that gets in the way. Like, can you just see that person?" And I said, "Sure." But once I started meeting with that person, I started to understand the way they were talking about their pain, that sometimes they have a pain flare. Their pain just shoots up out of the blue for no reason. And this happens at a restaurant with their friends. And suddenly they feel a lot of shame because people start staring at them. "Hey, what's wrong with you?" Right? And I just say, okay, like fear of pain, does that really describe what's going on? Is it really the fear of pain that is sort of amplifying the pain? Or should we think about it backwards? There's some characteristics of the nature of the pain that is triggering a fear reaction. So should we target the fear or should we target some of those pain characteristics? And that's when I started to be interested in stress, right? Can we think of pain as being stressful? We often think, oh, when you're stressed, you have more pain. Sure, that's definitely true. But can the pain itself become a source of stress?
Right.
And so that's when I started to read about Sonia Lupier's work, who's a world-known neuroscientist in Montreal in the field of stress. And she came up with a model that describes what are the characteristics of a situation that will trigger our body's stress response. Right? So when you're stressed, you have a whole bunch of things happening. There's cortisol, like your body reacts so that it can fight or flight. And researchers found that when we're faced with a situation that has at least one of 4 characteristics, our body will trigger that response. Right? So the acronym is STUN, S-T-U-N. So S is for sense of low control. So if we bring this to the pain, right? When you have a pain flare and you know that when your pain reaches that intensity, there's nothing you can do about it. Your meds are no longer working. You feel you don't have control over your pain. So that's stressful. The T is for a threat. So usually like a social evaluative threat when your abilities are put into question. Right? So when you have to cancel last minute an outing with a friend that you had planned for months because it's just not a good day, like it's threatening. So that's the second one. U is for unpredictability, right? Your pain is unpredictable, or you have an appointment with a physician and the outcome, you don't know if you're going to be believed or validated, or if they have something new to offer to you. That's stressful. And finally, N is for novelty. You wake up and pain moved somewhere else, or there's a new quality to the pain, or you prescribe a new treatment and the last time you tried the meds, you had a lot of side effects, so you don't know, like it's all new. So I started to apply that stress model to the experience of pain, trying to shed new lights or new ways of thinking about it so that we can move towards different interventions or different ways of thinking about the pain. And so that's an example of an idea that really came from the clinic and then getting patient partners involved in that project.
And there's so much there I can resonate when you talk about threats and unpredictability, and as I'm sure we all can, and having to cancel appointments and the stress level. I mean, this is incredible work.
Yeah. Just in that moment when you're talking about, the threat, not, wanting to cancel out an appointment or not wanting to miss out on something. And Keith and I'm going to speak for you in this moment, Keith, because we shared this experience where we were at NAPS, the North American Pain School, as the 2 patient partners. And then after a couple of days, we compared notes and found out that each of us had a really, really bad day, but we sat through it. And we didn't understand why we did that. And I think it was the threat of not learning or not being a part of that group, potentially, the way you describe it. So thank you for that.
Yeah. And as human beings, we all face those characteristics all the time, right? We all have different types of stress, but seeing pain through that lens, it sort of opens the door for, hey, it's not just about the person's reaction. This can be triggered by the nature of the pain itself. So can we pay more attention to this?
Well, I love that. And there's a couple of things here that I feel if I don't get out, my head's going to explode. First and foremost, this started with a hallway conversation. I love these organic, dynamic, hey, I got this patient who, or this person who, and then it goes into this. I just,
Beautiful.
one of our previous guests, we talked about how just sort of those ad hoc sort of dynamic conversations can lead to some of the most inspiring moments or interesting moments for research.
Absolutely.
Second, I love the idea because we know that stress, when we look at the biopsychosocial model, we talk about there's pain, which is biomedical, and then there's the emotional and psychological and spiritual and how that impacts it. But pain itself is the stressor. And I've been latching onto that sort of concept for a while just because I just think it is. And I'm going to do a shameless plug. A few years ago, I got to co-author a paper with a bunch of people. And it was about pediatric pain as a toxic stressor. And pain, I mean, that parasympathetic nervous system, which is supposed to be there for when you have moments when the bear is chasing you, is always on when you're having all of these moments. So I love this whole concept. And I just love the fact that you guys did it with a hallway conversation.
Yes. And you're touching on an important point, right? This system is made to help us in specific instances.
Right.
What happens when it never stops, when it's always solicited? So there's a lot of literature on exposure to chronic stress and how chronic pain and chronic stress shares a whole bunch of things in common.
I love it.
Yeah.
What else have you got for us?
So if we go back more to the action plan, I think it's no surprise to anybody, but like access to resources for pain has been a challenge across the country.
Yeah.
And the action plan in Canada trickled down in the province of Quebec, where I'm working, into our provincial action plan for pain that was for 2021 to 2026. And some of the highlights of that plan were about trying to measure what we're doing. And that's something that sort of makes sense, but it's really hard to execute. So when we develop new programs, when we offer care to patients, what we're doing, is it actually helpful? Is it effective? Is it optimal? To know this, we need data. We need to measure things. And in busy clinical settings, it can be a challenge to measure things. And so one of the items in that action plan was we need a culture of measure to know what we're doing. And we also need better interdisciplinary care. Right? We could do multidisciplinary, but just it's jargon, but it's really important. But multidisciplinary care is not the same as interdisciplinary care, right? So if I have a pain clinic where I have an anesthesiologist, family doctor, a physiotherapist, a psychologist, and a patient is seeing all those four professionals, most likely it's multidisciplinary care. You're receiving a whole bunch of approaches at the same time, but it's not together. It's not in a concerted way. Interdisciplinary would be, hey, I'm in the same room with the psychologist and the physiotherapist. And the physiotherapist would give me an exercise of moving my arm, and it really hurts. And I started to have all those thoughts about, well, am I injured? Am I aggravating my pain? And so the psychologist and the physiotherapist can work together to really help the patient move forward in their care. So that's interdisciplinary, but we really are not very good at doing this because it's expensive, because there's a whole bunch of logistic barriers. So in Quebec, they tried to implement new models of interdisciplinary models in primary care at the level where people should be getting it first, not like 10 years down the road.
Wow.
Love
and
that.
So there were 6 pilot projects, 6 clinics, and they were all free to sort of design it their own way in primary care. So some had a group format, some had more individual formats, some went to hire OTs, like occupational therapists or pharmacists or social workers or psychologists. So they each have a bit their own sort of model of care. But we're doing a research project where we're trying to document the implementation of those clinics. What's working really well and why? What are some of the barriers? Are those barriers related to how they decide to set up the project, or their systemic barriers that all of those projects are facing? So we're trying to go into implementation science, we call, to understand what happens when we bring innovations in primary care within a provincial ecosystem, what happens to those projects. So we're interviewing managers, we're interviewing clinicians, we're interviewing patients, and trying to understand, what are the best models, so then we can try to more cities in the province.
How fascinating
And
and innovative.
Yeah.
My gosh, this is exciting.
Yeah.
Gives me such hope for the future of pain.
Yeah, it's incredible. And have you found out anything yet? What's happening? And how will you get this out to other provinces when you know?
Yeah, well, there's different ways we can do this, but still very early on. I think it's interesting. One of my graduate students, Gabriella, is interested in how is psychology perceived within those interdisciplinary clinics. So a lot of those clinics try to hire psychologists. Very, very few were successful.
Oh.
But so it shows there sort of is a recognition that psychology, even at the primary care level, is an important piece in managing pain. But there was also findings about how it is not exclusively in the hands of psychologists. And so when you interview physiotherapists, they're confronted all the time with some psychological aspects, whether it's sort of motivation to engage in the treatment, or maybe it's fear of movement or fear of pain, or right. So how are physiotherapists, like how equipped do they feel? Or is there a need for training physiotherapists in some of those psychological dimensions? Or should they really go through, hiring professionals in psychotherapy or social work, or like what is the best format that we can deliver interdisciplinary care? So it's raising a whole bunch of questions and interest. There's, a lot of interest from family doctors who are saying, "Oh my God, finally we can we can help patients receive the care that they need at the right time in their trajectory." Because when it's been 10 or 15 years you're living with chronic pain, it's really sad when you just get the opportunity that far down the road to meet with professionals that could have helped you way early on.
I have a lot of respect for the family doctors and family physicians. And when it comes to pain, quite often they're the first stop that's made in the healthcare journey. And with no knowledge, like with really no training or education or supports, they're like, I don't know what to do. I need to refer you out. And starts the clock in months and years later. They go on. So to be able to give them some of those tools and that understanding where they're like, hey, there are some things I can do to help you with this and help you understand it. And maybe in a perfect world, change that trajectory or make it less. But I think changing that trajectory, and the other thought that I have is you talk about, the psychologist's role and, all the other healthcare providers. We hear a lot that non-psychologists say it's outside my scope of practice. We're not asking these people to be psychologists. We're asking them maybe to be psychologically aware and know that within their scope, there are many things they can do to help people without being you, a psychologist, and getting into your world. Is that fair to say?
Thank you for raising that point. I think it's super important to make that distinction, because a lot of people, I will say the majority of people living with pain or having normal psychological reactions to an abnormal situation. We don't need to psychopathologize, right? Sometimes it's about empowering people, saying, hey, we're giving you tools, you can do this. Sometimes it's about choosing the right words so they feel heard, they feel validated, they feel believed in that experience. You don't need to be a psychologist to do this.
Right.
But sometimes it's just not on our radar. So helping clinicians better understand how to choose their words, how just taking 5 extra minutes to listen, how much good it can do. So absolutely, there's definitely room for, as psychologists, that's other roles we're taking, how to help healthcare providers practice in the field of pain.
You have no idea how refreshing this is for me to hear, Gabrielle. And I think back to, 10 years ago when I was in the acute stage, and, it was a different perspective. And hearing that perspective today, and also hearing you earlier on saying, there was suboptimal trajectories that led to people seeing you further on down the pipeline. I'm paraphrasing what you said, but further on down the pipeline than ideal. And so what I hear in that is the potential for prevention of worsening of symptoms or some sort of earlier access to care and so on. If this interdisciplinary and truly thorough understanding is happening, I find it gives me such hope for the future of pain.
Yes. And so it's about an ideal world. It's about giving the right treatment to the right person at the right time.
Right.
And I think at the right time, we're really not doing a good job.
Yeah.
And those 6 clinics that I've mentioned in primary care, it's interesting, they all decided to organize it slightly differently. So some of those clinics actually decided to get their patients from wait list of secondary care clinic and say, hey, can we bring those people back to primary care and offer interdisciplinary care? And maybe they won't need to be seen in that secondary care level. Others decided to go through family physicians and get referrals from there. And others decided to go through orphans. So people who, maybe that's a term we use in Quebec, people who don't have a primary care physician. So they're orphan patient, meaning like there's no one managing from like a global perspective their care and saying, and for these people, if you don't even have a primary care physician, like good luck getting your pain sort of understood and managed. And so prioritizing those patients. And what's really interesting to understand is that regardless of where they decide to choose their patients from, most of them are benefiting from that form intervention.
Right.
I think it's incredible. I mean, you talk about right time, and I think too, bringing it back there and you get an interdisciplinary clinic within the primary care. And to me, it's like a dream. It also brings you back to having access to, and this is something that the action plan talks about, access to care in our communities. I mean, I drive an hour and a half to a pain clinic. And when your pain is the worst, or when you're in that acute stage, when things are just so bad, that hour and a half is like 5 hours. That's sleeping along the road. That's doing things that are not safe. So I think that brings that into play too.
Absolutely. And Canada is such a big country. And a lot of people live far from urban centers where most of the specialized services is concentrated. Now, the pandemic probably helped in some ways by democratizing virtual care. So for some aspects of care, it's possible. Like in psychotherapy, I think maybe 2/3 of my patients right now, I see them virtually because I'm a tertiary care. So we cover about, the province of Quebec, the west of the island of Montreal, all west and up north.
Wow.
Like some people take a plane sometimes to come down to see us.
Yeah.
Or just Montreal, with construction and orange cones and so on. Even if you live on the island, it might still get like an hour and a half to get to me.
Right.
And so how can you be present in a psychotherapy session when you're in pain because you've been driving for 2 hours and you were stressed of coming late because the bridge was closed? And that's not a great mind space to do psychotherapy. So in some cases, virtual access has helped. It's not always possible or recommended, but at the minimum, that's something new that we're able to offer that before the pandemic wasn't really talked about that much.
Amazing.
I just wanted to touch on, and Virginia, you said about sort of, the timing of like getting those proper interventions, and not to make this about me, but I'll just share a little bit of a story because I think, as you said, Gabby, it's, that timing is so critical and it can change that trajectory. And Jen, this goes back to our experience at the North American Pain School. It was the first time I had somebody ask me, they said, when do you think your pain went from acute to chronic? I had never thought about that before. And, my car accident was in 1986. It was pretty traumatic. And the first surgery I had was 7 hours. And the surgeon comes out and he says to my parents, well, he's going to live, but he's going to have problems later. Full stop. No, here's what we can do. Here's what can happen. Here are the supports. This is 1986. So medicine was a little more focused on just biomedical. So when I was asked that question at NAPS, I said, well, I think my transition happened probably while I was in the ICU because I didn't have any other path to go because I had all of this damage and pain and no path, just left on my own. So, and the psychological aspects are critically important because mine was a pretty traumatic accident. Never once was I offered to talk to a psychologist. So these seem so fundamentally simple. Why is it such a struggle to get it implemented?
Yeah.
I mean, you guys are doing great things in Quebec. What's wrong with the rest of Canada?
Great question.
Yeah.
The
Well, I'm
loaded
not sure.
question. Yeah. You have to solve the problem right now. You got 5 minutes. So.
And don't get me wrong. I mean, there's a lot of things that can be done better in Quebec. I'm just giving an example of new project, and it's like not that innovative. It's just like basic access to basic care that should be available everywhere. So I'm ashamed of talking about this from an innovation perspective, because it's sort of we're taking different professionals coming together in primary care. That should be the default, and it's really sad. And I think that speaks more largely about our healthcare systems. And when we talk about chronic conditions, right? So we talk about this in the context of pain here, but I'm sure we could list many different chronic conditions for which it's really difficult to get different type of professionals in the care path.
I mean, this is a bugaboo with me, but I keep thinking about if things like you're finding models that actually are really effective and work well. If the healthcare system was structured for that, how much would it save in terms of like disability time, impact on the economy, impact on the healthcare system? It's like could be potentially be restructured so that it makes more sense, costs less to Canadians overall. And to your question, Keith, is like, why isn't that happening? And so it's just, I can't emphasize enough how encouraging it is to hear that these models are being examined.
Yes. Yeah.
Absolutely. And we're not really good at documenting those economic costs, mostly because it's very complex. It's very hard to do.
Yeah.
But that's really an argument that speaks to managers, and there's a challenge of resources as well, and of how do we train clinicians to be formed in pain, and whether we call it chronic pain or persistent pain, or it resonates, Keith, what you said, because it's not like we have definitions in research, right? Usually it's more than 3 months, it's chronic, but it's so definitive. Right? And we need sort of that for research, because things has to be standardized and so on. But what does it do in terms of messages we're sending?
Right. Yes.
You know what I remember is a couple of things is that people are, my physician group, saying, oh, we really are hoping you don't become chronic. We really hope you don't become chronic. And I thought, I didn't really know what that meant. And then apparently I crossed over that threshold at some point in time. And to me, it was no different. It was the same as the day before. And the day before that, there wasn't a major change. And I think, that's something that like a piece of education in terms of like that. I don't want to digress here, but a piece of education for patients going through this, like for the patient themselves to understand more about that.
Absolutely. It's interesting to, when we think about the pain care trajectory, there's a shift, right? It's true that you're not going to manage acute pain like 2 days after the surgery the same way as you're going to manage it 2 years down the road, right? So absolutely, there's a pertinence in differentiating the type of pain, what's the source of the pain, and that often shifts through time. And so there's a lot of clinical implications to this, but from a perspective standpoint for the people living with pain, like what does it do, Jennifer, to be told like, oh, I hope you don't become chronic? If I go back to my stress model, I just put you in an alert state. Oh my God, what's that big monster that maybe will catch me? How helpful is this? And we get it from a clinical standpoint. It's much easier to treat acute pain. Once it becomes chronic, it can be more challenging. So we get it why that's being said, but we have to measure what's the impact of the words that we're saying also. And sometimes
it was scary to hear that.
We don't think about it.
Yeah.
Well, obviously, like I'm sure it was. And then it sets a whole bunch of, triggers a whole bunch of thoughts about, well, what's going to happen to me? And that state is not helpful, because then we turn up the alarm volume of your nervous system. And for what? Because there's nothing you can do in this moment to prevent it, or you're already trying to do it. And so sometimes just thinking about what are the words that we're choosing and what's the impact that it can have on us as clinician. If I have that thought, I hope you don't become chronic, it already tells a lot about my mindset. How am I going to treat that patient then in 6 months if the pain is still there? Or not the same way as if I was more hopeful that I can still do things that are meaningful, right? And it can also, as you said, like it's scary. It has an impact on the patient.
Yeah. Just goes to show how important the words that are used matter, because those are taken in so deeply by people who are living that, having that experience, for sure.
Yeah. And there's a study right now with Maël Gagnon-Mayotte, who's finishing his PhD, looking at suffering in the context of pain. So we did a study on stress, pain, and suffering. And one of the things he found was that at some point, there's a lot of stigma. We talk about chronic pain, a lot of invalidation that can come from so many different sources. But it gets to a point where we understand that it becomes internalized stigma. So that discourse that people hear from physicians or from family members or from coworkers not being believed, or maybe you're not like strong enough or whatnot. For some people, they start to believe this, right? And it becomes kind of internalized. Yeah. And then it can set a whole bunch of other difficulties. And so that how we think about pain and what we communicate about pain can really have deep and lasting impact.
Yeah. Yeah. And
I hear that often. So, sorry, go ahead.
Oh, I was just going to say just quickly, and so relevant in this moment, one of the additional challenges I've dealt with is not having a known cause for the pain. So it's left as undiagnosed. And the amount of stigma around that is significant in the sense that what are you doing wrong? Why hasn't it been figured out? Are you sure? All of these things that get asked of you because of you being on a route of trying to find the answers. And it has an impact, And so, I just think this is such a rich discussion in terms of, bringing that aspect of how important the psychology of pain is and how urgently it needs to be dealt with anyone experiencing pain.
Yeah.
And I think about the lasting impacts. Like I said, it had impact at the time, but I mean, I'm 10 years into this, right? And it's a huge lasting impact that even now when I tell my story, you have those triggers of these things, and it's a lot around the stigma.
Yeah.
Great point.
I think we're gonna wrap it up there for today. This has been just amazing. Thank you so much, Dr. Pagé, for joining us and for sharing some just absolute nuggets of wisdom. And I'm going to bring it back to the one that's just that I'm really sitting with, which is the pain itself, stressful. And again, I said it earlier, to have that triggered as a conversation in a hallway tells me that not all research, it's not all done in a big white lab or a big theater and all this fancy formal thing. It's people who care, like yourself and your colleagues, who have conversations and say, hey, there's this thing that's really bothering me and I don't know what to do. And then finding a path to explore it.
And I think the message of this is, as people living with pain, don't be afraid, don't be shy to come and talk to researchers. You have insights, and maybe your conversation will trigger something like this example, right? And so come and share your perspective. Come and speak with us. You never know where that's going to lead. And so please, don't be shy and start the conversation. You never know where it's going to go.
Love that.
Love it. Great advice.
Such an important message. And thank you, Gabrielle, for joining us. We'd also like to thank all of you for tuning in. We hope this episode has shed some light on the important work being done here for pain in Canada. Until next time, thank you.
Thank you.
Thank you for joining us today on Action on Pain. If you enjoyed the discussion, please follow us on your preferred podcast platform to stay updated, and please share with your networks. A 5-star rating and review would help others find our show. Your feedback is important.
This podcast does not contain any medical advice. Please consult with your doctor if you have any questions or concerns.
The Action on Pain podcast is made possible by the generous support of the Chronic Pain Network, a national research and knowledge mobilization network.
The views, opinions, and content shared by hosts and guests are their own and do not necessarily reflect those of the Chronic Pain Network or its funders.